Slightly.
Okay, here's Dr.
Okay.
Sharma and
Welcome
Dr.
from
Sardar
Brunei.
Farhan. Excellent.
All right, we have Farhan and Muthu and Gaurav. My team, Vicky and Ashley, right? All and everybody else, the same crew for, yep, you have moved the monitor away so we can see things.
Excellent.
Yes. So this is the case number 11. We jumped a little bit, but still the sequence wise. Very interesting. Wanted to show always something different. This is the patient, 67-year-old, had a PCI in the past, positive stress test, an anterior wall ischemia, good medical therapy, and here for the LAD intervention. And I'll show you with what LAD is in this case, particularly because of the ROTA or plus minus cutting balloon. So ROTA ablation, yes, plus minus cutting balloon. This is our trial. Where is the slide advancer clicker? Can we buy the advancer clicker? Yeah, move it, then move, good. So this is what we are going to do, ROTA cut concept. We start, this is the FDA initiated trial. The issue is, we usually do ROTA and high pressure. Question is, can you do cutting balloon? ROTA plus cutting balloon, use a smaller burst and yet get a good stent lumen. Next. And basically, there are some data to say. You do cutting balloon and with a rotational atherectomy, you have a better lumen gain. Next. So this is basically the ROTA cut trial with myself and Jeffrey Moses. 60 cases, pilot study. Next. And the trial is quite intense. Intense in the sense, multiple IVUS runs. So appropriate case which need to be for severe calcified. You do IVUS in the beginning, after rotablation, plus whatever you need to do, and then rotablation, then you do a adjunct technique, and then in the end. The end is blinded. So after we are all done, a particular investigator is not there for the final IVUS run. Idea is, it's the minimum stent area. It basically is the end point of the trial. So with that note, let's go back to the case. We are all set here. So this is the patient with appropriate, and look at this one. Already we did an intervention of which the RCA picture. Always we say patient comes back, even if it looks good, you have to take the picture of the previous picture of the PCI. With this is where we are. Click it. And more important is circumflex good. And look at this LED. And we'll ask the audience, I mean our panelists, aneurysmal, calcific. Everybody will be worried about that whatever is cause perforation. But look at the calcium. And I always say the calcium is that before you give the dye, you take a clear cine on those cases, and that will tell you a tramp track point of view. See here. See, you see the whole tramp track of the vessel. It's the severe calcium. Is it severe calcium? And then of course there is aneurysm. You'll have a discussion what our goal is. This case is that we have a ROTA cut strategy. Rotational atherectomy and ROTA cut trial with the cutting balloon. And we'll do some IVUS runs while you have a discussion ready. So right now, I had a fielder fine cross going to go through this lesion, change it to the ROTA wire, we require a baseline IVUS, which I think we should be able to go through once we navigate through this aneurysmal segment. Always happens the aneurysmal that your wire is free flow, less mag, go to a low mag. You don't low mag, okay. Yeah. Okay, so wire has been advanced, and we'll try to do, if this goes in, so we'll do a IVUS on the ROTA wire. Let's get the ROTA wire. Okay, George, you can have a discussion that in this tight lesion, will somebody think about doing this case with the IVL? But I can, lesion is a 90+%. Proximally, whether IVL will even go, need to be seen.
Yes, we saw that.
Yeah, see that.
Yeah, well, there's a combination of calcific lesion with aneurysm. Has any comments or reservations about this case? Maybe Dr. Waxman.
Yeah.
I think it's a very novel concept to go with this device combination, as long as the order is ROTA first and ROTA cut second. Because cutting balloon is not indicated for calcified lesions, but it can give you maybe better expansion. That's, I think, the premise of the study. I think that the concern about this case is that looks like an aneurysm there, that you want to make sure you're going to go safely there without any perforation, especially with rotational atherectomy, that you have control on that. Again, I prefer to do imaging if the IVUS or imaging catheter will go to better understand what is this entail. This aneurysm.
I mean, I would not have, let's say, without the trial, I would have just done the ROTA and then maybe in the end, if needed, imaging. But this we wanted to show. But as you said, I'm sure you probably have a connection with the FDA. I'll tell you why. Took us 1 year to convince FDA that cutting balloon in the severely calcified lesion after ROTA is okay. Took 1 year because this is an investigator-initiated trial. And there was so much difficulty back and forth. We provided our data of the database that combining is okay. We said cutting balloon is not indicated for calcified lesions. And therefore, we have almost back and forth combination. It's the Roxana Mehran's team really persisted with all the questions I answered, provided our data, and finally, we have approved. This is the investigator-initiated study with the FDA sponsored. But you are right. The biggest difficulty we had was to convince that it's okay. This is strategy we use in our clinical practice. Okay, so here, it doesn't go beyond. So that's okay. How are we doing for the...
Okay,
can we see
even the start of the pullback, like 270 calcium. So I'll start pullback from here. Is a mid.
Can you see that aneurysm or no?
Not this all of the aneurysm part. The 270 calcium. Here is a big chunk.
This is that aneurysm. See that?
This is the aneurysm, big vessel.
And then should be a very tight lesion after that.
Yeah. Yeah, it's also 270
Full circular calcium.
Yeah, 360 calcium.
1.5 will be okay.
Diffuse
1.5.
All right, Ran and others to tell us what we do after this.
Okay.
I was it didn't go after that aneurysm, which is okay. But we saw that circular calcium before the aneurysm and a little bit had the distal part. The question is, I know that if IVUS did not go through, IVL alone will not work. So we are here with a 1.5 ROTA bar and ready to do a rotational atherectomy unless there is some objection.
175 is this?
So, I think the
now
concern is obviously, atherectomy in the thin wall aneurysm you want to be really careful of. So the stenosis really seems to be before the aneurysm. So I would try to not do atherectomy in the aneurysm. But the other thing with IVL, I think it's an interesting IVL case. And even if you can't cross with the IVL, you can use a 2O balloon and then pass the IVL catheter. And that was done in about 20% of the cases in the approval trial.
Why is this not running?
Interesting. Mario, what do you think about robotic or non-robotic Lima to LAD? I see you anxious in your seat. Hybrid revascularization. RCA has some stents. There is a patient is on dual antiplatelet therapy. There you go. Lima to LAD, robotic or not. Doable? What do you think?
Well, George, as you know, that has been the future for the last 20 years. So there is a reason for that. And the reason is that I think the concept is attractive, but it's not for every patient, it's not for every surgeon.
Would it be for this one?
Well,
Okay, we are testing.
I understand you guys are focused on the angiogram. I would like to see the patient around the angiogram.
Yeah,
and that would give me a lot of information of how easy or difficult the case would be in patient with
What is the BSA for this patient? BSA?
chest and height.
Now, this
What is
patient
that?
actually the average height and
It's a
weight,
difficult
non-diabetic.
operation.
And BSA is 1.95. So it's a good case for robotic and nothing against that because of aneurysmal. And we'll see if there's any trouble we do now. Before we continue, I think if you can go back to room 1, they say that Dr. Keeney crossed that lesion and they're ready to put a stent.
Let's go back to room 1.
Yeah.
Let's go back to room
So we
1 then.
complete there and then they go to here.
And then we come back to you quickly. Dr. Kinney, hello
Good, no?
there.
Yeah, we are good.
Oh, you see us? Okay, good. All you went away and we recrossed. So remember, we changed our strategy. We pulled back. And then with the same Gaia, same thing. You see that cap? If you
Yeah.
can see in this view, it is actually beaking.
Yeah.
So you needed a wire. short proximal, so it's very difficult to get a wire. That's why I took Miracle, exactly the reason for Miracle, so that I can get into the center of that proximal cap. But looks like Miracle would not go further. Then Gaia took us on the upper surface, came back, and when we entered the proximal cap, and then I think with the, this is where we were after we re-entered with the Confianza. Same
Confianza
wire,
Pro 12,
pulled back,
successful wire.
And yeah,
Excellent.
with the Confianza 12. So if that, I think going back to the point was same. We were initially subintimal and we tried Confianza, would not. If not, what would have been the next choice? What I would have done next? Change the guide, go to just FCL, so that we know it is just for, facing the LED. And like Nitin Barman mentioned, could we have gone with the curved catheter, like a supercross or something, so that we know it faces the LED more. And what are the wire escalation? Let's go back to the wire escalation. So we already were with Confianza 12, which is 12 gram. So the next that is available for us would be either a Progress 200, which is about 13.8, or Hornet, which is also close to that 14. Yeah. But Gaia 4 goes up to 10 grams next series. Otherwise, I mean, we didn't need it, but if you truly have calcium and your re-entry, if I was not able to go with Confianza 12, then I would have gone with the Progress. It's very good. It's a polymer jacketed wire. The tip has a hydrophilic coating, that's not a spring coil. Tip is spring coil, which is with a hydrophilic coating and tapered. So many of these CTO wires, what's the great thing about this new generation wires, many of them are tapered. And I hope they're showing our app slides in the side, where we have a library of over 130 coronary guide wires, and we discuss every wire, the property of every wire. I think as intervention cardiologists, it's good to know which wire works in which situation. We also have over 20 cases, complex cases, showcase which wire to be used to where. So after that, the fine cross actually went all the way down. We exchanged with a 300 run through, pre-dilated with a 2.5 balloon, and now we have a 48 millimeter synergy because patient had synergy on the other vessels. So we're just going to place one stent. We are just focusing to make sure ostial LED is covered, and that's where we are. Any questions, George?
No, I think that was very well explained. Any comment from Dr. Huber?
My question refers to the diagonal branch. Isn't there a significant stenosis immediately at the site where the LED was occluded?
Is there a diagonal stenosis? That's what you mean? Yeah. Well, I guess we'll see after the stent. It's very difficult to distinguish right now with the equipment and all that. I think there is an intermediate lesion. Is there a diagonal?
I don't think there's a significant lesion. Here, there's no significant lesion in that diag. You see here?
No, I understand, but is there a significant lesion after the crossing? That's the question of course.
Okay.
We'll see.
No, I thought he was mentioning. Okay, ready?
Greg thinks there's a lesion there. He said it from the beginning.
Yeah, in the AP cranial, it looked worse.
There's an intermediate lesion there. That doesn't show it. It doesn't show it at all because it's overlapped, so it's good. No lesion seen.
In the AP cranial, it looked worse. Your setup shot.
I did not think there was a lesion, but
okay. Well, you see it better than we do. It's the conference monitor is a little far away from us.
Okay. Time for some vasodilation, and I think
it
we're
looks
done
quite
with this
severe. New to us, it looks quite severe in this view. The osteodiagonal. That doesn't look severe to you?
It's a great collateral to it.
No, now after stenting, there is side branch stenosis, but I think again same thing. It probably would say 80% we can recross and kiss. Yeah.
Yeah, I think it's reasonable to do a little recross and kiss. It's probably maybe there was a 50% or something lesion, very borderline at all. And now after all this work and scratching it with wires and putting a stent and all that is jailed. It's get a little worse. All right, we don't have to stay here unless you want us to stay. We'll go back to Dr. Sharma.
No, I think you can go back, finish that case, because I'm about to start the second CTO in room 2. So
very
here
good.
we will recross, kiss, we give vasodilators, and otherwise LED is done. We see all the branches patent, which means that everybody suggested, go proximally and re-enter proximal. That's what we did. And this is where we are.
Sounds good. Let's go to room 3. Great job. We'll see you in room 2 in a little bit. Let's go back, Dr. Sharma, ROTA cut case.
All right. So we showed the IVUS, the circular, and I would say that I'm glad that a panelist agreed. I always wanted a little cutting balloon, the diagonal to be taken care because it's a good size diagonal. I mean, we need to really open that up. But there is now a little more pinch. Even originally was some blockage, but definitely now you have to have a good result of this. Okay, now we are ready with the 1.75 bar ROTA Pro, as you can see here. And now question is, and then this is the kind of case we could have perforation. Pull the wire. So we have actually, I say some of these tough cases, you have a papyrus stent ready. Whether it's a Joe stent or papyrus ready in the room, not in the cabinet, which sometimes may take 30, 40 seconds. So this is the kind of case. We have it ready here. Good. So now, question is, the speed check outside 150, we have the ROTA Pro setup, 150 speed, all of them. And then you have do what same, the technique point of view. First, we have to pull back the wire. Wire is quite good. Yeah. So now, once we have the proximal, 3 things: at advancer knob, at the Y connector, simple thing. An idea there is that will prevent and just a tap on the Dynaglide and will not jump. So with that note, we are ready to start. We have 1.75 bar ready, although it probably would have taken a 1.5. We'll see. If we see some resistance, and same, packing. Touch, come back. No, we did not cross yet, and it's the RPM, because of the angulation, went down to about 130. So we are going to upgrade our RPM to 150, 55. I know that one small randomized trial of 100 patients didn't show any difference, low or high speed, but we go with the low speed usually, 150 and so. Good, 150, yeah.
Somehow we can't
I'm not
hear
doing a daughter, but touch and come back, yes.
We can't hear the burring. I don't know why. I don't know. Is it stalling or is it we don't hear the burr? I don't know. Anyhow, but we do see the burr advancing and, the slow motions there.
Don't hear the noise of the burr?
No, we don't hear the noise of the burr. No, is there I don't know. But we hear you. Is there there may be, let's recheck the voice, the volume connections from this room, please, AV team. Otherwise, this is a little bit of a silent movie.
So, George, when you do a case like that with the aneurysm, you have on the shelf or next to you a covered stand ready to open?
Yeah, papyrus.
Papyrus,
What is that? We have to show the factoid with a papyrus, pericardius, antisis, tray, and protamine. There is a factoid we have, but we rarely use it. I think this is very, very good, very, very good technique crossing. It went all the way, pretty stable, I'd say. And for anybody who had doubts regarding whether this case required a rotablator, the difficulty with which the bird is advancing, I think this makes the point very clearly. This is severely diffused disease all over.
Just for the crowd, it's an interesting point that you didn't hear the burr noises. Burr noises
with a brake release.
Is it different if it was a pseudo-aneurysm versus an aneurysm? Because I think also that that part you need to take into consideration.
Just to go over that again.
And there is a lot of calcium distally.
I mean, if it's a pseudo-aneurysm, you would never put an atherectomy catheter next to it.
Go ahead, John.
Even the pitch,
Well,
you really need to be
you either-
listening to the burst sound,
And I mean,
because
there were
even the
3
pitch will
walls in
tell
the
you when you're
aneurysm.
about
There
to
was a 3
stall,
wall
when you're not
structure.
going to stall. So
Yeah.
it's the first thing that you react to. It's not the odometer, it's not the speed on the machine. It
Yeah.
really is your ears.
Yeah, no question about it. But indeed, the aneurysm seemed to be a little eccentric, to say the least. I don't know if it's pseudo or a circular-like, but definitely an eccentric aneurysm.
Run through.
One can say in that location.
Well, it's
very curious to see how we are.
It's a real aneurysm. It's not a pseudo-aneurysm.
Yeah.
'Cause you can see the 3-wall structure.
I was always in Greg's camp that I wouldn't necessarily want to burr into an aneurysm.
Okay.
And may have tried a non-compliant
Yeah.
balloon and then shockwave.
Well, let's see. First of all, the pressure is good, so there's no perforation, Dr. Waxman. We'll take down this factoid. Very good.
I will take this.
All right, so let's see.
You know, another question, how do you treat aneurysms like that? I mean, right now we don't have any good covered stent and nothing label on that, but do you leave those big aneurysms by themselves or you cover them if you had a good device?
No. In this particular case, as you saw, there is a lot of disease distally. Even after the aneurysm, look at the calcific. So we are going to cover it, and actually we have published that what you do is you go proximal to distal segment, long segment of stent, and basically what happened is we actually have a jack intervention case report. After when patient comes back, you have proximal to distal, you don't need the covered stent. So what will happen is the aneurysm, there will be no flow, and we have a follow-up CTA and angio on that RCA. With one of the fellow we presented, published. So what happened, because of low flow, it closes up by itself. Flow becomes very little. So aneurysm actually becomes just half in size.
Yeah.
And you'll see here that in this particular case, that is what's going to happen now. This is the run-through wire. I have my ROTA wire there, and we are going with the 3.5 balloon now to open it. And you are getting ready?
The so-called end-to-end technique, normal to normal.
Yeah, normal to normal. And that's what we are going to use here. What is stent supposed to use here?
It's a synergy because the RCA got the synergy.
Yeah, because
stent.
synergy, it will use a 3.5, 38 synergy in this case. Because it was a 3.5 vessel by our IVS imaging. So go up here and leave that wire to a modified cutting balloon.
I have 10,
But since this patient is not in the trial, 6, 8, 10, 12, 14,
12,
16.
14, 16.
Now, lesion has to open before we go further, and if required, maybe we combine with the IVL. It's a 1.75 bar. This area bar did not complete. So we just stop at that level, and that is what I have been making a point, probably less traumatic,
14,
because
16.
now you have IVL. And I think that one of the advantages of the IVL with the synergy, it's not only just the synergy maybe for stent expansion. I think IVL will decrease our atherectomy complication, be it may ROTA or orbital. Why? Because we'll use a lower speed, we'll use a smaller bar, and that's what will happen.
Going up.
So this is at the level
14,
of aneurysm,
16.
and somehow patient is having hiccups. You see it, the diaphragm having a very aggressive movements, and I know that Dr. Keeney will be ready in few minutes. So this is here. So question comes is here that angiographically we are okay, or we have to go with the IVL now. Go up again.
I don't know. I don't think so.
So can you IVUS and
not, yeah.
show us how you've
14,
done
16.
18, yeah. Yep, we'll do it now.
with
Good.
rotational?
We'll do the IVUS
One
again.
difference between rotational atherectomy and both orbital atherectomy and IVL is that you don't get as deep calcium fracture. So the ROTA cut concept makes a little sense because you can hopefully extend the depth of the calcium fracture. With OAS and IVL, you tend to get very deep calcium fracture, so you probably don't need a cutting or scoring balloon.
Right.
Okay.
So essentially,
All right,
you
so
crack
we
a
are
little
here
bit,
now.
and
I
then
was
you open
now
up the
again.
crack. Yeah, that would be interesting to see the IVUS assessment of this concept.
Also, everyone's always worried about stenting across those aneurysms because you're going to, almost by definition, have 3 millimeters of malapposition.
Almost, yeah.
But
We
that's
did the
not a
IVUS.
concern.
We
That
did the
is
ROTA.
absolute no
And I can
risk
tell
of
you
stent
after we-
thrombosis as long as you've got really good expansion of the stent.
Right.
Stent. And then more importantly, by the time we'll be done with the stent, I can guarantee you this aneurysmal size will become half. As I mentioned, because of no flow, And that is what else happened now.
Yeah.
Okay, we are here. Start the IVUS quick.
Okay, check the imaging. Yeah, good healthy part. Okay, start to work. But this part, it looks like vessel size is 2.5.
3.5.
But normal vessel.
We are way
is
distal
coming.
yet.
Yeah, now calcium plug start. Yeah. 1 cordon calcium, some blanch. Yeah, lumen is getting bigger. Here is like 3.5. Or like aneurysm part. It's,
But at least there is a cut, right? There is no circular calcium. So Greg, your point that it's not a much deep calcium superficial or there, we have made some cuts.
I see that.
And at this area, it's not a full 360 degree, only 180. Now we are getting to a little higher. This was the one, we got a good lumen of maybe 2 millimeters. It was 1.75. This is the aneurysm.
This is the aneurysm part.
And now we are going to come a little proximal.
Oh, let's see.
Okay. Yeah.
This is the proximal lady. Still
Good.
coming.
Okay,
Still coming.
good. With that note, what we are going to do is we are going to put a stent.
Sure.
Then you'll go to the room 2 for Dr. Kini, and she will do this another CTO case. And once she crosses, we can put that on the side.
38.
And then
38.
stent.
Step, give us
So
the,
put it on the side and
stent.
complete the case, and you will start your lectures and so. So far, so we are good.
416 synergy.
No, stent, we are-
Interestingly, with
But
the
I'm sorry. This
Tell the
was
stent
Yeah,
what we need.
it's interesting to see
3.5,
that proximally you
Still
pretty
360
you
degrees
sanded the
calcium.
lumen, but you didn't make deep cuts into the lumen. So
Ideal
you
they
made the
have.
lumen larger proximally, but you didn't make the deep cuts. So it would be nice to get something that would
Yeah.
cause deep fractures in that proximal lumen before you start
Well,
trying to
question.
stent it.
Greg and
See, right here, see here, you were still almost 300 degrees of calcium.
but
But
hopefully
we have
with some
shaved
cracks.
it. Remember, we have shaved it because we went through the bar.
Well,
Because from that point of view,
Right,
that
there's still
clearly that
360
human
degrees of
yeah,
calcium.
OCT may tell us exactly how much we shaved, but we know that we went through the lesion, so it has to do some shaving
28 not gonna cross.
and so. So here, we are ready with it's a 3.5. Huh?
Well, Dr. Duvuri brings up the possibility, which obviously another approach,
38.
the ROTA shock approach. Instead of the ROTA cut, with the ROTA, and then you do a shock wave. That's another approach, I
Yeah.
suppose, for extending and do that. It's just not exactly
Yeah,
this
that's
approach.
that's
but
actually what I would
some-
favor personally,
Yeah.
because I know that you're going to create deep cuts in the calcium with lithotripsy at this point.
To improve the compliance, right?
Absolutely.
Right. So, no, I think the question comes is you are absolutely correct. That at what point now you bring IVL in this particular case. So that's, I think, a very good point. So I would say 2 things. If I had not done the imaging, or imaging says that, yeah, lumen is looking good, we have made some cuts, interruption, it's okay. And it's not a deep calcium, which we have modified. Or secondly, I would say that if you do you have done the ROTA, just you go to high pressure balloon or cutting balloon, little die. And if you, little further, yeah, 1 second. Yeah, go up here. So this is a 3.5 38 synergy XD, and we can always, we can post dilate. Look at the stent, nicely expanded at 14 atmosphere. Stent usually we do 14 or 16. And angiographically, of course, since this case we did IVUS, we are going to repeat it again. But I can tell you once angiogram, if looks good, it's rarely, because we had modified the plaque. And of course, sometimes you can just do our stent boost to see the results.
Oh.
Okay, let's take a picture here, so we can let them go to other side. Good. Look at the aneurysm size.
Yeah.
See that aneurysm has become half the size than before. This is how exactly we published on one case report. That aneurysm actually was 8 millimeter, became 4 at the time of the stenting with a 4.0. So with that note, if everybody is okay, we are ready to move on to our room 2 for another CTO with Dr. Kini.